I now want to talk through my approach to the conscious chest pain patient. We were presented with a few of these throughout the semester, and in doing that and a bit of my own research and a bit of practice, I've come up with a very basic approach, but I'll annotate it the way through I read it in my head. But yeah, I've got a flow diagram that I think best describes it. It's very simple, but like I said, I'll talk you through what I think when I read that, and I believe it best sums up my approach to the conscious chest pain patient. So initially, just like any other case, you want to start off with the standard precautions. That is that you have your gloves and your overalls on and that you're protected in every way possible. And obviously these need to be in place before you enter the premises or any location for a job. The primary survey, that involves a danger surveillance. Obviously in scenarios it just counts as verbalizing either any dangers, but in the real situation you have to verbalize and look for yourself for any dangers. If there are any dangers, obviously they need to be addressed before anything can go forward, and that can include danger to yourself, the patient, or any bystanders, or even pieces of equipment. So they need to be addressed and removed or neutralized as soon as possible. Following dangers, the next step of the primary survey involves getting or gaining a response. This can be a verbal response, so announcing your premises announcing your arrival when you arrive on the premises, and trying to elicit a verbal response from the patient, or if this isn't the case, you can go down the line of trying to get a motor response or a verbal response based on stimulus such as a trap squeeze. But for the conscious chest pain that I'm talking about, we were always able to elicit a verbal response. For this conscious patient, once the response has been gathered, it's safe to assume that their airway must be clear and that their breathing is able to sustain a level of consciousness, and that circulation can be assumed that it is occurring, or it's a very, very unlikely or pretty much impossible that they would still be conscious and alert and talking to you. Following that, the last step of the primary survey is the hemorrhage check. So this can be a quick visual inspection for any hemorrhages. Once again, in scenarios, it's purely asking the assessor, are there any hemorrhages? But obviously in the real world, it needs to be assessed. So once the primary survey has been completed with the conscious chest pain patient, it can start moving on to the information gathering. The two best acronyms that I've found work for me are DOLORS and AMPLE. So obviously you'd find out the reason why they've called you there today, being sure to use appropriate language. I like to use that phrase exactly, and what can we do for you today instead of why have you called us here, because one can sound like it has other connotations involved, whereas if you ask what can we do for you today, it shows that you just want to help and you're willing to help in any way that you can. So with your DOLORS, so this is your primary information gathering. So description, so can you describe to me how you're feeling today? Is there any pain involved? If so, how would you describe it? Being sure to ask questions that aren't leading questions. You don't want to just say, oh, is it a sharp pain? Because then they might just say, oh, yes, that's we'll go with that. But if you maybe throw out a few adjectives and then see which one they pick, or don't lead them down a certain direction. You might be thinking about it, but be sure not to lead them that way within your questioning, and keep them very simple questions. So once you grab a good description, you want to try and elicit the onset, and I'm just going to say now, this doesn't need to happen in this order, obviously. If they move on to another point in answering one question, you can continue with that and come back to any one you missed, but sometimes it's a bit easier and logical to just follow the flow. So the first O is onset, so trying to find out how long they've been feeling this way. Good question to ask is, was it as bad when it first came on, or has it been getting progressively worse? How long ago did this come on? Has it been feeling the same the entire time? So trying to get a really good picture of time frame wise the onset of these feelings that they've been having. If there are feelings involved, such as pain or uncomfort or tightness or whatever it might be. So location is a very good hint that back in one of my first tutes, our practical tutor told us with location, ask them if they can point to it within one spot. And this can be a really good indicator for whether it is pleuritic or cardiac or traumatic. Because if they're able to, with one finger, point to the location where it's sore, you would think it's not a dull, aching pain across the whole of the chest, that it might in fact be a pleuritic pain or traumatic pain that something has happened to a specific area. So this can be a really good differentiating question between pleuritic, cardiac and traumatic. So yeah, that's the type of questions you're trying to find out, and obviously does it radiate anywhere, such as your jaw or your shoulder or the arms or anything like that. So then you move on to the other signs and symptoms. So question I like to ask again is, if I could take away whatever the primary discomfort is there anything else that's bothering you today, whether it might be nausea, vomiting, uneasiness, or whether they're anxious or stressed or anything like that, trying to elicit, trying to grab a full picture of what might be happening. So then you move on to relief and aggravation. With a lot of the chest pain ones that I had during the semester, the patient was kneeling over, holding their chest. So a good question I like to ask was, does kneeling forward, having your hand on your chest, make it feel any better? Or is there anything you're doing right now that makes that pain or discomfort or whatever they're feeling a little bit better? And at the same time, is there anything that you can do that makes it worse? So this can be a good time to find out, such as pleuritic pain. Does it hurt on inspiration? Does breathing make it hurt? Is there anything else that makes it worse? Is it a pain that becomes worse when you're doing a certain movement or a certain action, or is it a constant pain? So then, especially if pain is involved, getting a good scale or a good severity on a scale of 1 to 10, with 1 and explaining this to the patient, 1 being no pain and 10 being the worst pain that you've ever had, where would this sit at? Or it doesn't have to just be for pain, it could be for discomfort, uneasiness, just to make sure you apply the scale to the right form for the patient. So after you've done that, you move on to your ample. So do you have any allergies? Pretty simple question. Medications, what medications they're on, especially with some people, as I had in my few scenarios, that they were on quite a few medications, especially if they have had prior heart problems. So they may be on a beta blocker or ACE inhibitor, or aspirin. There's a very, very large amount of medications that people get put on once they've had prior heart conditions. So that's a good question to ask, and get a full list, and possibly get your partner to go get the medication so they can have a look and figure out what medications they're actually on. And that can be a good example of leading into the next question of past medical history. So medications can give a good insight into that, but it's also good to ask them what sort of medical history they have. Do they have any previous health conditions? Have they had any operations? Is there anything health-wise that they think we should know? Establishing that past and whether this might be related to that. Just moving on to your last oral intakes, when was the last time they had something to eat, can help with establishing whether it's indigestion as well as for surgery purposes if they need it. And E is obviously the events leading up to it. So that's a really important question that shouldn't be overlooked, in that it can help differentiate between different forms of acute coronary syndrome. So it can help differentiate between whether it might be unstable angina, what they were doing leading up to it. Were they sitting down just relaxing and it came on? Were they out running and it came on? So it can be a really good differentiating question. Anything involved are the events that led up to this pain and events that happened once this pain occurred. So I think at this point it's a very good thing to think about considering calling for backup. Once you get a good history taking and a good information gathering about the case and the patient, I think it's quite safe to start drawing a few conclusions, and it might be obvious now that you may need backup indeed. You can start also thinking about transport at this stage, but I'll come back and talk about that a little bit later. But I think at this stage, like I said, this can be done later on as well, but it's good to start thinking about calling for backup because you'd rather do it sooner rather than later if it's necessary. So then obviously taking good baseline vital signs is really important. Taking a blood pressure, taking a heart rate, chest auscultating if appropriate, temperature, blood sugar levels, whatever you deem appropriate, with the key ones obviously GCS, like I said, blood pressure, heart rate, rest rate. And with your vital signs, of course, if it's anything cardiac or chest pain, you're going to attach the cardiac monitor and do a 6-second lead printout, have a look at all the leads, and that can also be really, really key in leading into the next step of your primary diagnosis. Giving yourself a really good baseline to understand where the patient's at, and this can also help lead into whether you need backup and also transport, working out time criticality of the patient. So once you've got a good picture of what's happened and what you think is happening, and you've got a good vital sign survey, I think it's appropriate to start thinking of a primary diagnosis and maybe talk to your partner about what actually might be going on. Keep the patient informed with what you're thinking initially, but I think it's appropriate, like I said, to start making a primary diagnosis So obviously once you've made that initial diagnosis, start treating as if that was the case. This can involve medications, it can involve simply transport. This is where, based on the vital signs, you would decide as well, whether GTN is appropriate, and based on the information gathered, with the good knowledge of all the standard precautions and contraindications and indications, which I'm not going to run through now, that I'll include that in my domain knowledge section, but this is just a approach-wise view. Your aspirin and also whether morphine is appropriate, if they have pain, greater than 2 out of 10, so you want to be sure that you can safely rule out all the contraindications for any medication that you want to give, but also whether they are actually indicated in the first place. So once you've performed your initial treatment, it's always really good to take another set of vital signs and just see whether that's actually had any effect or whether it's any desired or adverse effect. So obviously if you're giving GTN, you might want to especially take blood pressure again. If you're giving aspirin, any form of medication or any form of treatment that you perform, you want to be taking vital signs afterwards as well to see the impact that it's had. So then you'd be thinking about transporting, obviously. So you've arrived at the scene, you've gone through your primary survey, you've gathered a good information, called for backup if necessary, you've taken your vital signs, you've made an initial diagnosis, you've given some treatment, and judge based on the results of that treatment whether transport is appropriate, whether the patient needed to be transported. That's obviously based on the case. But you can see on the flow diagram that transport I've put as sort of after the primary survey at any stage. So really, transport shouldn't be a set thing. You should be thinking about, does this patient need to be transported? Do they need to be transported urgently? Can it wait until I make a diagnosis and start treatment? So transport is really something you should be thinking about during your entire approach, and obviously this is very individual with what case you're at and case dependent of what you need to do, but I believe this is a very good structured basic approach that lets me go through each step individually, leading to making a diagnosis and starting some treatment. As I said, the approach on the screen is very simple, but I believe I've just talked you through and annotated specifically for cardiac what is involved with each of those steps, and in my mind how I interpret that situation. So that's my approach to a conscious walking, talking chest pain. Obviously if the patient presents as that and then falls into an unconscious or altered conscious state, then that needs to be adjusted appropriately and needs to be reacted to under a whole different set of guidelines and a different approach entirely, which I'll also talk about in this page of my portfolio.